Here we'll talk about glycemic targets required to be in pregnancies, recommendation fasting, and postprandial self-monitoring of blood glucose are recommended in both gestational diabetes mellitus and pre-existing diabetes in pregnancy to achieve optimal glucose level. So what are the targets? Fasting blood sugar should be less than 95 milligram. And first hours better to be less than 140 milligram per deciliter, or second hours less than 120 milligram per deciliter. Some women with pre-existing diabetes should also test blood glucose pre-prandially. Lower limits are based on the mean of normal blood glucose in pregnancy. Lower limits don't apply to diet-controlled type 2 diabetes. These values represent the optimal control if they can be achieved safely. So in practice, it may be challenging, for women with type 1 diabetes to achieve these targets without hypoglycemia, particularly women with a history of recurrent hypoglycemia or hypoglycemia unawareness. If women cannot achieve these targets without significant hypoglycemia, the ADA suggests less stringent targets based on clinical experience and individualization of care. Due to increased red blood cell turnover, A1C is slightly lower in normal in pregnancy than in normal non-pregnant women. So ideally, the A1C target in pregnancy is less than 6 if this can be achieved without significant hypoglycemia, but the target may be relaxed to less than 7% if necessary to prevent hypoglycemia. This slide, as you see, when you use an addition to pre- and postprandial blood glucose monitoring, continuous of glucose monitoring can help to achieve A1C targets in diabetes and pregnancy. When used in additional to blood glucose monitoring targeting traditional pre- and postprandial targets, real-time continuous glucose monitoring can reduce the macrosomia and neonatal hypoglycemia in pregnancy complicated by type 1 diabetes. So continuous glucose monitoring metrics may be used in additional to, but should not be used in substitute of self-monitoring of blood glucose to achieve optimal pre- and postprandial glycemic targets. Commonly used estimated A1C and glucose management indicator calculation should not be used in pregnancy as estimated of A1C. So pregnancy in women with normal glucose, in women with normal glucose metabolism is characterized by fasting levels of blood glucose that are lower than in the non-pregnant state, due to the insulin-independent glucose uptake by the fetus and placenta, and by mild postprandial hyperglycemia and carbohydrate intolerance as a result of diabetogenic placental hormones. In patients with pre-existing diabetes, glycemic targets are usually achieved through a combination of insulin administration and medical nutritional therapy, because glycemic targets in pregnancy are stricter than in non-pregnant individuals. It's important that women with diabetes eat consistent amount of hydrates to match with insulin dosage and to avoid hyperglycemia or hypoglycemia. So referral to RD or RDN is important to establish a food plan and insulin to carbohydrate ratio and determine weight gain goals. So I'll talk here about insulin physiology. Given that the early pregnancy is estimated of enhanced insulin sensitivity and lower glucose level, many women with type 1 diabetes will have lower insulin requirement and increase the risk of hypoglycemia. Around 16 weeks, insulin resistance begins to increase, and total daily insulin doses increase linearly 5% per week through week 36. This usually results in a doubling of daily insulin dose comparing with the pre-pregnancy requirement. The insulin requirement levels off towards the end of the third trimester with placental aging. A rapid reduction in insulin requirements can indicate the development of placental insufficiency. In women with normal pancreatic function, insulin production is sufficient to meet the challenge of the challenge of this physiological insulin resistance and to maintain normal glucose level. However, in women with diabetes, hypoglycemia curve treatment is not adjusted appropriately. About glucose monitoring, reflecting this physiology, fasting and postprandial monitoring of blood glucose is recommended to achieve metabolic control in pregnant women with diabetes. Pre-prandial testing is also recommended when using insulin pumps or basal bolus therapy, so the pre-meal rapid-acting insulin dosage can be adjusted. Postprandial monitoring is associated with better glycemic control and lower risk of preeclampsia. There is no adequately powered randomized trials comparing different fasting and post-meal glycemic targets in diabetes and pregnancy. So we'll talk about A1C in pregnancy. In studies of women with pre-existing diabetes, increasing A1C levels within the normal range are associated with adverse outcomes. And the hypoglycemia and adverse pregnancy outcomes, HABO study, increasing level of glycemia were also associated with worsening outcome. So the observational studies in pre-existing diabetes and pregnancy show lowest rates of adverse fetal outcomes in association with A1C less than 6 to 6.5% early in gestation. Clinical trials have not evaluated the risk of benefit of achieving these targets, and treatment goals should account for the risk of maternal hypoglycemia and setting of an individual targets of less than 6 to 7%. Due to physiological increase in red blood cell turnover, A1C levels fall during normal pregnancy. Additionally, as A1C represents an integrated measures of glucose, so it may not fully capture postprandial hyperglycemia, which drives macrosomia. Although A1C may be useful, it should be used as secondary measure of glycemic control in pregnancy after self-monitoring of blood glucose. So in the second and third trimester, A1C less than 6% has the lowest risk of large for gestational age infants, preterm delivery and preeclampsia. Taking all of this into account, a target of less than 6% is optimal during pregnancy if it can be achieved without significant hypoglycemia. The A1C target in giving patients should be achieved without hypoglycemia, which in addition to the usual adverse sequelae may increase the risk of low birth weight. Giving the alteration, the red blood cell kinetics during pregnancy and physiological changes in the glycemic parameters, A1C levels maybe need to be monitored more frequently than usual. We can do it monthly. continuous glucose monitoring in pregnancy, as per concept trial, was randomized control trial of CGM, additional to standard care, including optimizing of pre and postprandial glucose targets versus standard care of pregnant women with type 1 diabetes. So it demonstrates the value of continuous glucose monitoring in pregnancy complicated by type 1 diabetes by showing a mild improvement in A1C without an increase in the hypoglycemia and reduction in large for gestational age, birth length of stay, and neonatal hypoglycemia. So an observational cohort study that evaluated the glycemic variables report using continuous glucose monitoring found that lower mean glucose, lower standard deviation, and higher percentage of time in target range were associated with lower risk of large for gestational age birth and other adverse neonatal outcomes. Use of CGM reported mean glucose is superior to the use of estimated A1C. So glucose management indicator and other calculation to estimate A1C, giving the changes to A1C that occurred in pregnancy. Continuous glucose monitoring time and range can be used for assessment of glycemic control in patients with type 1 diabetes, but it does not provide actionable data address affecting and postprandial hypoglycemia or hyperglycemia. There are no data to support the use of time and range in women with type 2 diabetes or GDM. The international consensus on time and range endorsed pregnancy targets range and goals of time and range for patients with type 1 diabetes using CGM as reported in the ambulatory glucose profiles. Target range 63 to 140 milligram with TR goals more than 70%. Time below range less than 63%, 63 milligram with a goal of less than 40%. Time below range less than 54 milligram per deciliter with a goal of less than 1%. Time above range more than 140 milligram per deciliter with a goal of less than 25%.